working with addiction is beautiful, and because addiction is a very important area in neuroscience.
She is very accomplished, so I'm going to make it a little brief. Professor Zhao, PhD, MD, psychiatrist, and Vice President of Shanghai Mental Health Center.
Because at that time, China, there's the drug issue in China is not a big issue. So there's no way, no treatment. So I miss him very much. He come to China, and this during this Invest Fellow, I go to NIDA. This is Steve Gott, which is the international director. So for the research part, lastly, I would like to share some of our research work, which I'm very interested to do that. Expert consensus we developed in China. The R1 NIH project support way. I developed a longitudinal cohort study on heroin dependence. So there are some of them.
Hello everyone, and welcome to our monthly talk series, 11th one. My name is Amir Rezvani, and it is my pleasure to introduce our speaker today. She is very accomplished, so I'm going to make it a little brief. Professor Zhao, PhD, MD, psychiatrist, and Vice President of Shanghai Mental Health Center, affiliated with Shanghai Jiaotong University School of Medicine, and worked as a PhD advisor, clinician, and researcher. She got both her bachelor and PhD from Shanghai Medical College in Central South University of China, and as a NIDA Invest Fellow, she completed her postdoc for 1 year in 2002, and as a distinguished exchange scholar for 3 months in 2005 in University of Miami, USA. Dr. Zhao has been engaged in clinical teaching and scientific research in psychiatry and addiction field since 1994. Her research involves the basic and clinical research for substance abuse dependence. She has received more than 20 research grants, including major projects from the Ministry of Science and Technology, 4 grants from the National Natural Science Foundation in China, and 4 projects from WHO and NIH. She was the Associate Editor of General Psychiatry Addiction and International Journal of Mental Health and Addiction. Dr. Zhao is a member of the informal scientific network of UNODC and consultant for WHO. She is the Vice Chairman of the Chinese Expert Committee on Drug Abuse Prevention, the Vice Chairman of the China Association of Drug Abuse Prevention, and Chinese Hospital Management Association of Psychiatry. She has received more than 10 international and national awards, including NIH and NIH-NIDA Distinguished International Scientist Collaboration Award and Chinese Distinguished Female Science Award. She's very accomplished, and I actually try to make it a little bit shorter, but if you want to see her resume, you have to spend probably 30 minutes to read the whole thing. And let's welcome Dr. Zhao. Dr. Zhao, it's yours.
Okay, thanks, Amr. Thanks for your very comprehensive introduction. Dear colleagues, and I'm very glad to be here. I saw some familiar face here, so thanks for joining the meeting. So also I would like to thank the organizer, which is ISAM and International Brain Research Organization, to organize this important sales talk. So it's my great pleasure to be here to share my personal path in the addiction and clinical and research field. I'm introduced. I'm a psychiatrist, and also do some teaching and do some research. This is my, I want to share the outlines I want to share this evening. First, I would like to explore my personal information, as well as my team and my institution. Certainly, I will share some of my clinical research work in addiction, and then I will share some of my other works, including education, training, and international collaborations and international connections. Lastly, I would like to share some of my thoughts, my personal thoughts, and the future planning. Okay. First, I will show my path. I got my PhD. I got my MD in East in Central South University, Shanghai Medical University. Then I do my residence in the same university, but the affiliated hospital. In the mental health institution. Then I got my PhD in 1999, major in psychiatry. Start from 1994, I started working in the addiction field because my PhD thesis is about how to help the addiction patients to get recovery. So during my PhD dissertation, I introduced the recovery model, some psychotherapy, introduced that into China and use that in the patients in the addiction field because. At that time, China, the drug issue in China is not a big issue. So there's no way, no treatment. I don't. There's the institution is only start. So the drug treatment center is very rare. So the patients they only have the drugs. So the patients don't have place to get treated. Then after my PhD, I changed my workplace. I go to Shanghai. This is my present working place, Shanghai Mental Health Center. We call that ISAM-NIG. So and in 1999, I come to Shanghai and established the drug treatment center. Just established 2 years before. So come to Shanghai, start working in the drug treatment center. So during my early careers, I want to find more effective rehabilitation or treatment models. I apply the NIDA Invest Fellow. So then I got that. I go to University of Miami to go to my mentor is Howard Liddell. So he's focused on MDFT, so the family therapy, multi-dimensional family therapy. So there after 1 year, I come back to Shanghai and still working with my patients. Then in 1905, I go to University of Miami again for the advanced for the distinguished international exchange scientist. So from that on, from the 2005 I start to apply research funding. So I got my first NIH the grant when I working with the University of Miami. I submit the NIH the R01 to the NIDA, and luckily I got that grant, and then I come back. Start my my professional career then. And next, I would like to let you know what my institution looks like. What my institution, Shanghai Mental Health Center, has a long history. It was established in 1935 as a Mercy Hospital. At that time, it's more like it's poor people. They come here, they homeless. But in 1958, so there's several private and public psychiatric hospitals. We merged together and established the Shanghai Municipal Psychiatric Hospital. So from this time, we become a mental health center, mental health psychiatric hospital. So we treat all kinds of patients with mental illness disease. But as a social development, our center has more and more responsibility, like research, like teaching international. So we change our name as this time the Shanghai Mental Health Center, which we have a more comprehensive role. This is then in I think then 1997 we have a drug treatment center, but in 2006 we joined the Shanghai Zhao University School of Medicine. So we become the affiliated hospital. So this is our center. We have two campuses. One campus is in the central city of Shanghai. Another campus is in the is a little bit far from the central city. But right now, you mean Shanghai is a very huge city. So there's like 25 kilometers between these two campuses. So as I mentioned, Shanghai Drug Addiction Treatment Center. So I was the director for this center for 8 years. But this center is established in 1997. Then I come from Shanghai Hospital in 1999, just 2 years after it is established. Then I'm trying to find the effective ways and to provide the service. But for our center, we have many other roles. We are the WHO CC, so that's why I'm involved in many international communications, working with the WHO, and then I'm become the only member of the ICD-11 for MBD. So because our center is the oldest center of WHO, and we are keep working closely with WHO. So our center also is the first and earliest psycho counseling and psychotherapy center. So this building, I don't know any of the colleagues have been in our center. So this is the first psychotherapy center right now. And we have a CDC, so for mental health. Also, we do have other national roles, such as we do clinical trial center for the national level. We also have other roles like prevention and crisis intervention. We have a hotline for the government. And the Shanghai campus have more like the headquarters of our center. In the Minhang campus, more chronic patients is there, and the research building is there. We have the two campuses have different styles. Minhang Hospital is much more older. You can see the building, and the Shanghai Hospital is built later, so it's a more like modern buildings right now. So this is our center. We have many research departments, like Shanghai Key Laboratory for psychotic disorder. We have many other research units. So under Shanghai Drug Addiction Treatment Center, we have a drug addiction research unit. So which is I'm working on. I'm the leader of this. So this center we have full-time staff about 1,300. The inpatient beds is more than 2,000. So that's why we are the largest mental health center in China, and the highest level in Shanghai. So I'm not going to go details, but we are the very comprehensive entity. We provide not only provide a service to provide psych-counseling, we also do prevention and rehabilitation and research, education, and training. So this is like very multi-function role. So basically, we are the mental health hospital. So then, this is my team. So we Shanghai Drug Addiction Treatment Center, as I already told that, because the drug problems is relatively very late in China. So the Drug Treatment Center is established in 1997. So it's not so old. And this is the unit. So this is a gate, and some of my team. We have 30 time staff, including nurses, doctors, and social workers. And we are the very provide outpatient and inpatient for service for all kinds of addictive disorders. So the inpatient beds is not so much. We only have 13 inpatient beds, which is in these areas, in this building, and we have guarding here. So, but also we have many PhD and MD programs here. So I would like to mention that since 2005, the UNODC launched a TreatNet project. So we are the only member of TreatNet in China. So this project, the goal is to improve the capability of drug treatment. So we under this project support during 2006 to 2011, we carried out 5 series of senior U.S. joint training program on drug abuse treatment. So this project we focused on to training the professionals in China. Also, we do some research, both basic research. We collaborate with other neuroscientists. Our group is mainly focused on human studies or clinical studies. So the aim of our research is mainly focused on how to improve the clinical practice, how to develop new treatment models, so which I will share that later. So we also involved in policy advocacy and guideline development and public education, which we think is very important. And international collaboration is very important, I think. So we developed many international connections, which I will share that with all of you. Okay, so later I will share some of my own works. So as I mentioned that my PhD thesis is focused on psycho-behavor intervention, which we all know that addiction, the medication for addiction is not too much. So psycho-behavor intervention is the main model. So in early my research careers, many of my research is focused on heroin dependence, and because before like 2010, I think 10 years before, the number one drugs in China is heroin. So many of my early research project is focused on heroin dependence. We did a series of psycho-behavor intervention studies, like relapse prevention and CET, which is cognitive enhancement treatment, and continuous management, and psychosocial intervention, and CBT. So we develop the protocol, and then we do a series of clinical study, and all these study are RCTs. So we prove it works. Then we integrate that into the treatment center, so to treat our patients. This is one of my early part. Then under the, as I mentioned that under the R1 NIH project and support way, I developed a longitudinal cohort study on heroin dependence. So there are some of the publications from the longitudinal study, like we found that the polyol drug use patterns can impact their relapse after the recovery. Also, we see after the rehabilitation or after the return to society, there's many the patients have different paths or recovery paths. There's many risk factors related to their 5 years relapse rates. Also, some other substance use can impact their recovery. Then, as I told, after 2010, the substance use pattern is changed in China. I think the methamphetamine use, this type of use, or the synthetic drugs, become more and more popular in China. So we shift our study and interest to MI dependence or methamphetamine dependence. I mean that. So we find that compared to heroin dependence, the main outcome, the main negative consequences that we find the methamphetamine users, many of them, they have psychosis, and they have cognitive impairment. So we did a series of studies. We found that compared to the controls and the MI dependent patients have many domains of cognitive impairment, and their quality of life and their mental health status is impacted. And as we know, there's no effective drugs or medication for MI dependence. So we are thinking about how to impair this kind of cognitive impairment or neurotoxicity. So that's the way we keep in mind how to do that. So we do more study to look at where the methamphetamine impacted their brain. So we can see their main domains is effective function, compulsive hypertrophy control were impaired. You can see after baseline or 3 months, they still the executive function is still impaired compared with controls. And we also look at the underlying mechanisms, and we found that the GABA system is involved in MI dependence. Also, you can see with image study, we found that their brain function is decreased in the PFC. So that's why we consider how to pair that. We think about some brain modulation, and maybe it's helpful to fix this kind of neurotoxicity. So we do more study. We found that not only the function is impaired, the structure of the brain also is impaired, like the micro structure deficit is still exists even after 1 year of recovery, and their gray matter also decreased. So that's why so the methamphetamine dependence is also a brain impaired their brain, and it still is how to give us some hints how to fix that. Then we found that the brain is impaired, and how we repair that. So we know rTMS, it's a brain stimulant, and it's a model for effective for other psychiatric patients. First, they used for depression. This is good that it's non-invasive, and it can modulate the neural plasticity and the brain connections. And our previous study showed that the MI have impaired the brain connection, or the GABA also involved in the brain damage. And some studies showed that the rTMS fix the brain by modulate the glutamine and the GABA functions. That's why we try to do this study. So in 2000, I think it's the way we do the first study. They first explored a pilot study in 1917. I think it's 1917. So this is as I know, is the first publications on items of methamphetamine. So this is a very simple study. We only do 5 days intervention, and we found that the rTMS compared to the sham stimulation, it can decrease the craving significantly. Then we do more study. We do more study, and we found in multiple site study, and we confirm our result. And then we found that not all the patients is effective. Then because I forgot to mention that the stimulation location is DFPFC, so we try to combine to stimulate the two sides, two locations. One is DFPFC. I can see that DFPFC, and another one is LPTFC. So both we found that we compare two location stabilizations is more effective in decrease the craving than the one side stimulation. So that's we think maybe the addiction have more to have not only one pathway involved in the impairment, but also not only other locations is also very important. So it is effective, but why is important? So we do the image study. We found that the cue-induced craving for after 4 weeks of rTMS is associated the brain function connection between DFPFC and IPL, which means inferior partial lobe increased. So this connection is increased because along with the craving decreasing. You can see among those who have a craving change, the craving, the change of craving is positively related with the connection. That means maybe this the connection between DFPC and IPL was involved in the craving treatment. Okay, that's some of our studies. Next, I will share one of my another study. We call that CARD study, which is a cohort of addiction-related disease in China. This CARD study is supported by Chinese government. So this main purpose of this project is to establish the large-scale clinical data and biological sample bank. So we establish a cohort from normal controls and occasional use drug users and drug user disorders, and we followed it for three years. So this is our third year right now, and then we follow up the outcome, and we collect their blood and other biological sample, and we for the patients we explore new interventions, which I will share that later. So this is a national clinical big data and biobank based on the CARD study. So we have 21 hospitals joined this cohort study, and we collect a very comprehensive clinical data, and we use a structured interview by Yale University, and we collect their image data and their blood sample, and we try to find some biomarkers and to for diagnosis or for the predictions. Okay, that's the Cohort study. And so for the research part, lastly, I would like to share some of our recent work, which I'm very interested to do that, because in addiction, psycho-behaviors or addiction treatment is very time-consuming, or we need much of human resources. So in recent years, we tried to develop some AI-based or digital medicine in the development, in the assessment and treatment or recovery management. And this kind of we can use for gaming disorder, for use for the drug addiction, for screen. So I will show some examples of that. So we use VR, so virtual reality, for assessment, and combine that with psycho-behavioral therapy. For example, mindfulness based relapse prevention, and psychotherapy, and some recovery management system. And also we designed a computerized cognitive therapy for addiction. So I show some more on that. This is where we are. We use EEG combined with eye tracking and some psychological physiology marks. So compare that to find that this character changes is related with drug-related craving. So we use that for craving assessment, and then next we will develop some ways how to decrease the craving. So use the same philosophy. And right now we use this system in our research. So it's provided a subjective way to measure craving. This is a CCAT. We call that computerized cognitive therapy for addiction. So as we find that there are MI dependent patients, they have cognitive impairment. So we, based on their cognitive impairment, we designed a system to fix that. So which we compile the drug use cues and with cognitive training. We have 10 modules, 5 modules, and 10 tasks. You can see that we did a clinical trial, and we found that it is useful to decrease. So you can see this session is 20 sessions, last for 4 weeks, and each time is 1 hour. We use many tasks to evaluate the outcomes. So this is main outcomes. So the research showed that it's effective in increase the like working memory, and decrease the attention bias, or improve the risk decision. So which is very promising. So another system or we designed, I want to share is that the rehabilitation management system, we call that care system. We design an Apple IPP for the doctors, for the social workers, so they can follow up them and to do real-time evaluation. Because in China, all drug use addicted patients are followed by the social workers, and they are required to be evaluated regularly and provide some neuron tests. So this is a regulation in China. So we use the care system to help the social workers and the doctors to follow up the patients and help them to recovery. So this is you can see the app and the doctors. You can see some of the evaluations like emotion, like we smoking and alcohol use. And so this also it's our pilot study showed that it is feasible and it is workable. The another one is we for in the rehabilitation center we working closely with other colleagues. So we did, to help them to design the protocol, to training them for methamphetamine dependence. So previously we explore many tools to help the patients to fix their cognitive impairment, but we think it's very important to integrate all these tools together and form a model to the clinicians here. So we do that. We propose a model for methamphetamine dependence. We call that WARM model, which means that the whole course and the accurately and repeatedly measure, and it is a measurement-based accurate whole course model. So which also consists with chronic disease. We need we need to detect their brain impairment, so which based on the measurement. So this is we propose that, and then we hope we can integrate that in the system, in the drug treatment center in China. So also I mentioned some of the treatment effective treatment. We also including that in the guidelines of this is a Chinese. I don't know. You can read that. It's methamphetamine stimulus disorders guideline, the clinical treatment and the guidelines. So that's I think that's what we do. Another the most recent work we do is we use the AI in sex therapy. So you know that the sex therapy is the main way, the main model for addiction, but human resources are very shortage. So we think maybe we use the AI to treat the patients. So we have we combine with the CBT and the motivational interview, relapse prevention. There's 10 modules, and it's a very structured system. So this is AI person, the virtual person, which means they can talk with patients. So this is one of my students for his master's degrees. So from this study also proof it's effective. Okay. I think that's the research part I want to share with you. So then I will share some of other works for training. So as I mentioned that we are involved in the ICD-11 MBD, but for my personal interest I'm most interested in the substance use disorders and addictive disorders behavior chapters. So we needed the field study in China, which was supported by the WHO. I don't see. Do you see the Vladimir? So he come to China, and so we launched the study. So this is a mature site study in China, which means we are here in Shanghai and Beijing. Beijing. Beijing is here. Yeah, we have five provinces involved to study the reliability and the utility of the ICD-11 for SUD and gaming disorder. So the results showed that it's pretty good. So the very good guidelines for diagnosis and substance use disorder is very good. So another thing why we are trying to do is supported by the Chinese government. So they give us some funding. We developed a screen tool for gaming disorder based on ICD-11. Also based on the screen scores, we use some brief intervention based on the assessment for the young people. So this is some of our students or teams working with this field study, I think. And another thing I would like to mention about the gaming disorder is that so this is a government institution for disease prevention and control bureau department in Chinese. So under the government coordinating, we developed an expert consensus on the prevention and treatment of the gaming disorder in China. You know, the gaming disorder in China or other Asia countries like Japan, Korea is a very serious problem among young adolescents. So the government is pay much attention on that. So this expert consensus is translated or briefly introduced in English. So if you are interested, you are welcome to see that, to look at the details. But in this expert consensus, the key, the main content is over the definition and the clinical features of the gaming disorder and the factors contributing to gaming disorder, and how to diagnose it and evaluate that, and what's the principle we should we should do if they have gaming disorders, and future perspectives we proposed in China, which means more research is needed and much sectional work coordinator working is needed, and policy is needed, and something like that. And for the public education, we think it's very important. We develop a very brief key message for public education. This is you can see the very friendly. The page is very briefly. Main content is definition and main characteristics. How to prevention for the young people. Something the key the key message we would like to convey is that the family and the kids should have health habit. We should have a good parent the children relationship. They should have adequate activities and interesting. But if they have some problems, they should seek help from the professionals. So this is an expert consensus we developed in China. And another thing, I think I should mention that we do research, but we do research, should do research based on the present the environment. So the COVID-19. So during the COVID-19, we developed another expert consensus how to prevention and treatment of the patients with substance use and addictive behaviors. So this is more than 30 experts from China. We work together and develop this concept, which is, I think, is very helpful. We also published some commentaries for the. You all know that medical maintenance in China is very popular, and there are almost 1,000 clinics that. So during the COVID-19, how to modify their service so to decrease the infection possibilities for the medical clinics. So we write a commentary article about that. So addiction is a chronic disease, and we think that prevention education is very important. So another part of our work is doing to do some prevention and education. This is some of our study. It's a director of the Shanghai Drug Treatment Center, which is our main member of my group. We develop some microfilm. We develop a set of we call them the public education class, which is 31 sessions. This is we collaborate with King's College. We translate this MOOC into China. Yeah, so lastly, I also would like to mention some of our international collaborations. I think mental health and addiction is an international issue, public health issue, so we should work together nationally or internationally. So we organize many international conferences or conducting some collaborative research with many international researchers, and we sign many MOU or jointly apply some research project with international collaborations, and also we jointly working on some publications like this. So actually, there's a series of publications with that. So the most I would like to share is our single WHO and ICD-11 training programs, because we are the only center we do the field study of ICD-11 MBD in China. So we think we should do some trainings here, because the Chinese government promised that we should be the first among the first countries who adopted the ICD-11. So since 1918, which is ICD-11 MBD officially announced. So we launched a series training programs. So we call that although that should be This 中四班, how to say that? This is a Chinese WHO class in that. So we already finished the 4 rounds of the trainings. Each round, all this audience will be the trainers in future. So what I would like to mention is for the today's topic, so addiction. So last year we developed we do the session for substance and addictive behaviors last September. So September in Shanghai, and this is training programs. We use real patients interview, and we also invite some international guests. Maybe you know them. It's Zhao, and this from Edinburgh, I think. And John Sanders, Professor John Sanders from Australia. This is training topics, and I'm not going to go details about that. So both John and John will talk about gaming disorders, because the Chinese audience is very interested in gaming disorders, how to diagnose them, how to deliver some service, how to help them. So this is very important, I think. Also, we go other province to was invited in other place in all across China to deliver the trainings there. So we write Chinese article to introduce the ICD-11 and to prepare for the to form adaptation in future. So right now we are translate the ICD-11 MBD into Chinese, and we hopefully next year we in China it's available, and the government will use a new system which was have our contributions. Another international project I would like to mention is the SONID project. This project is funded by German Academy Exchange Service, so DIDD project. We are the one of the 5 countries. There are 5 countries, including Germany, Kazakhstan. This is I'm not the 5 countries which coordinated by Frankfurt Institution for Addiction Research. The purpose of this project is to fund the early career researches in social works, in social studies in addiction field, which I think is very is consistent with the aim of this I Love Addiction series talks. I think it's the same purpose. So in this project, we have 4 candidates which funded by this project. 1 postdoc and 3 PhD. So which we help them to increase their research and their capability, so to help these young people to love addiction and to work in this field for a long time. So some of their research topics, including the longitudinal outcome tracking and social work needs. So training the social workers and to develop some effective rehabilitation modalities. Also need to develop more artificial intervention-based assessment and intervention, which is very needed by the community social works. Yeah, I think this is a last few last slides. And during my academic career in addiction, I very proud that I established many international connections, and I thanks for these collaborators and friends. I think that's what make me to step to right now. So I think I can show some in my university. This is for my infant fellow in University of Miami. This is my mentor there. So I miss him very much. He come to China, but and this during this invest fellow, I go to NIDA. This is Stephen Gast, which is a international director. So we met him, and then I got more chance to know many international collaborators or colleagues, which is very beautifully, I think. Then in 2005, I went to University of Miami again for my scientific, for my exchange scientist program for 3 months. And then I met more international friends, colleagues. I joined the UNODC treatment project. So this or treatment project activities. I have a chance to go to UCLA, which I met some of my colleagues, the collaborators, Waterland, Ian, and Tom Barber. Later we have some collaborators, which that's very good, and we should go to Egypt for training. We go to Nigeria for ISI training, so that's very enjoyable. And after that, I have a chance to go to many countries, like in Germany, I met Ingo, and then we become good friends. And then I have a chance to go to the SONIT project. We just mentioned that. And he's director of the Germany public health, I think. So he's wonderful. He came to China working with his wife in Shanghai for two years, and that's very good. And then Australia for a conference, I think. This is Vladimir, so I met him for more than 10 years, I think. Robert Ally, and then this is for ICD-11 people. Go to Spain, go to Abu Dhabi. This is you see many good friends. We call them ICD-11 people, colleagues. We to go to India, Canada. So that's very beautifully, I think. And many colleagues also come to China. So this is, I think, this 2006. The UN people, the treatment people, come to Shanghai. We visited this our center. We have a museum for our center, and this is for ICD-11 meeting in Shanghai, which we hosted. My mentor in University of Miami, he came to visit us, and Betty Tai from the NIDA Waterning from UCLA come to Shanghai, and also this long-time Nora Walker, how many, I think 15 years before come, and then this more later. So I think I miss them very much. I very enjoy working with these international colleagues, and it's a must, very beautiful. Okay, so I think almost time. I think in future I enjoy working with the addiction field, but I think there's a lot of challenges. We should work very hard. So still there are much work to do, especially in China. We should improve the capability. We need to develop comprehensive treatment and rehabilitation modality. And I think each country has their own model, but the basic or the principle is the same. So we need to keep working, help the patients. So before say goodbye to colleagues here, so I would like to address several more words, which is my personal experience or personal thoughts. So I always say that working with addiction is beautiful, and because addiction is a very important area in neuroscience. I always say that in the psychiatry field, many animal model is not stable, but addiction, the animal model is very stable. And we can move the neuroscience forward by working with addiction, because substance, they are addicted drugs can mimic all kinds of mental health symptoms. So by research doing addiction, we can expand our understanding for our brain science. So we should choose working, which is a very important areas in the world and in our country. So addiction, of course, is meet this criteria. I think it's a long time work. We should combine our work with the needs. And also, if we can change the knowledge, the clinical practice, and this improve the quality of life, I think use our expertise. So that is very enjoyable. So we also should do balance the research, teaching, and practice. Most importantly, I would like to say is that talented young people is most needed in move this area forward. So I think teaching, mentoring is also important. Of course, international and national collaboration is very important too. So stick to your dream, enjoy your journey, and the beauty of the working in addiction field. I enjoyed that very much. Okay, thank you very much. I think this is my first time to share my personal career or working and in the international audience. So there's a lot of people I would like to acknowledge. My mentor, my PhD angel, Justin Yang, virtually Zhao, Howard Lido in University of Miami and Clyde, and working also many of my collaborators in Professor Fan, they are all in US, and the colleagues, teams, and my students, of course, and some of the organizations. Chinese government give me a lot of fundings, research fundings, and WHO and NIDA give me the international fellow. So I open my mind, open my eyes. I met so many international colleagues and distinguished collaborators and UNODC and NIH. Thank you very much. I also very look forward to working with you all. That's it. Thank you very much.
So much, Min. It was very informative and comprehensive. I'm sure there are some questions. There's one question in the chat box asking if do you use buprenorphine for the treatment of heroin? Because Irensat is effective, and they have been using it as a sublingual or by injecting once a month. Buprenorphine, do you use that for treatment of heroin?
Okay, Amr, thank you. Thanks for these questions. Yeah, buprenorphine, in China, we have two we only have two, I think, two formulas. One is Pierce, the sublingual one. Another one is the combined with naloxone. Yeah. So the pure buprenorphine we use that mainly for the inpatient treatment, but right now we don't use that for maintenance, for long term. We most of us mostly used for the detox. But in China, you know, the heroin dependent patient is decreased. So in detoxification, we use methadone more popular. But for some of the patients, we use buprenorphine. And the combined the Suboxone should be Suboxone is we have 3 companies to produce that. So that's for the outpatient, some of that. But because the patients is available, but the patients is not much. And more people is working is in the treatment of methadone maintenance treatment. Is more people than that because it's free. But
okay.
Okay,
so we've had methadone for years as well, and buprenorphine started in 1999, and I think last year or something like that we got buprenorphine as injectable, because the thing is then you don't have to give the patient anything. Here's an injection, come back next week or come back in 4 weeks time. Of course they often have social services and people talking with them, but there's probably more people in Denmark on heroin percent-wise, I think, but some of them are actually working, like being a gardener or doing woodwork or something like that. And then, of course, if they only really have to come every 4 weeks, then they can do their work and work full-time, which is really a good thing. And we don't have to give them any medication into their pocket. They just get the injection and then they can continue working. So for some people, it's actually brilliant. And yes, we have Suboxone. We also have Suboxone as a sublingual little gel thing, which is nice because then they can have it in their wallet, and it just looks like you have a cleaning serviette in your wallet, but it's just a little gel thing that you use for Suboxone. So that's also good. So I think what we try to do is have many different ways of treating, because there's no one that fits all. So we have everything, almost everything available, because people are different. So that's our principle, I think.
Yeah, definitely. So we should have all treatment or medication available, because each individual have individual needs, and they have their own maybe preference. Yeah.
And a very nice with all your high-tech approaches. We are not really high-tech in our clinic with VR or stuff like that, but it's nice that you do. We're sort of more down to it like that. So,
It's because the technology is developed so fast. We don't want to be left behind, because digital medicine, is in everywhere. So I think it's everyone has the digital phone, and there are many apps. There are many with WeChat. We have small program can do everything. So that's why we think about that. Yeah.
Yeah. Thank you.
Thank you.
The next question is from Masood, and he says, I'm going to ask about the effect of COVID-19 on patients' behavior. Did you find any noticeable features in these patients, psychological or other features?
You mean for substance use disorder patients?
Yes, or other, yes.
Yeah, we do some surveys in Hubei province when the epidemic start. But the epidemic in China is controlled very quickly. So but right now it's a new normal stage. So at that time we worry about that. So we do some surveys in the methadone clinics. So we found some patients they don't have they are risk patients. So we think they need to come to the clinic every day. So then we ask we do some surveys to see if they experience some worries, some anxieties. Yeah, they do have some anxieties, but they think they should come to every day. So then we give some suggestions. We should take home. They should take home the methadone. So then it's better. But we don't have large sample of the surveys. We only notice some patients. But I think more consequence is come from the general patients or the mental health patients. We do see some more people because of COVID-19. So we did a national survey for the general population, and we found that 30% of the general population, they experienced the anxiety, and we call that stress associated symptoms.
Okay.
Which I think, very popular.
Another question is,
sorry, I have asked a possibility to ask also to this last question. I am Dr. Adriana Bagiu. I am an ISAM member working as an infectious diseases physician in Bucharest. We have treated more than 5,000 COVID patients in our hospital in the last 13 months. And it's real that almost 1/3 of them develop anxiety, develop depression. We have even a case of one lady who lost about 20 kilos because she developed a very bad anxiety of fear of death. She was, when she was asked to put her oxygen mask, she was on a high airflow. She was really scared that she will die. On the other hand, there are very few patients with addiction who really got COVID. Actually, next week in CPDD and NIDA forum, I will present work that the incidence among people who are really active drug users coming to needle exchange and people on methadone, because sadly in Romania since 2 years we don't have even Suboxone, is not more available. But in people with addiction, they have very few cases of COVID. And I have found that the explanation maybe was offered by a study from Italy, who said that people with addiction, with methadone and with drug use have lower levels of serotonin. And the receptor for SARS is on the same place with the serotonin receptors. So having fewer receptors, like in dopamine and in serotonin, because of use and very years of use, they are less receptive to COVID.
No.
That's very interesting.
Very interesting.
Yeah. Oh, because we don't have many patients, so we don't know notice that. Yeah, because so that's interesting. So there's some discussion about the relationship with like alcohol and the COVID-19 infection rates, but I read one, I think one study from NIDA. Yeah, the Nora Walker, I think she published a paper, so showed that the substance use disorders is a vulnerable population for COVID-19.
Just a quick one about Copenhagen. We didn't have any COVID cases amongst our patients for a long while, but some street addicts got COVID in December 2020 or in January 2021. There was, I don't have the exact number, but between 100 and 200 of the street addicts got COVID, but none of them got very ill. And like one of my patients who's HIV positive, she didn't get ill at all from COVID. So maybe it's because the immune system does not overreact. And that might be an advantage for the immune system not to overreact to COVID, because they didn't get ill, you know, they didn't go to hospital, nothing really happened. So that's actually funny. So
yeah, that's probably, yeah.
There's another question that, from Sepide Elmi. Can you explain more about gaming addiction and prevention, and how prevalent is gaming addiction in China?
We saw a lot of treatment seeker treatment in all patients. We see many families or family members will come to seek treatment, but in China we don't have the national surveys for the gaming disorders. So we try to search some of the literature, find that the prevalence of the gaming disorder is very variable. Because they use different questionnaire or instruments. So from 2% to 40%, we can see these figures. But I think this is not consistent, because the survey is not, the instrument is not the same. So for our work, we design screen tool, use the app, we based on the ICD-11 criteria. We use this criteria to screen choose in a professional middle school, so which is a very high risk population. So this is a young adult, it's an adolescent in the professional school, by the high school. About, I think you said the screen tool, we have 19 questions. We found like 20% of the adolescents meet the threshold scores, and among the 20%, about like 5%, they meet the diagnosis criteria. This is what our studies show, but this is only very limited populations. So the screen scores after this screen, we will provide some interventions based on the risk level. Because if they are under the screen scores, we just give them some information, education. If they are in the higher risk level, we will give more advanced assessment and do provide some interventions. The main prevention, the treatment or the intervention right now we are doing is doing family groups, or doing some. So first we will give a very comprehensive assessment to see if they have some other comorbidities, because adolescents have some ADHD or some anxiety. So if they have other comorbidities, we will give them some medication combined with the family therapy or some other psycho counseling. So right now it's a situation here in China. I don't know if that answers your question. Thank you for your question. But I think there's much more need to do in future to do research.
Right. Another follow-up question is that is there any evidence that multiple frequent relapse in internet and gaming disorder correlate positively with extent of the damage to the brain?
This is a good question. I read many literature that the gaming disorder have the similar damage in their brain, but our group right now is don't have this kind of data to show that. There's a lot of literature show that they have a similar neurocircular damage, or in their brain. I think they're similar because it belongs. That's why it belongs to the same areas of addiction. So the brain is damage. Definitely, I think it's related to the severity or the how long they get the disease.
Okay, great. Thank you. Parnion, is about the time now? Is it?
Yeah, exactly. So we have 2 minutes left. So I think if there are no other questions or comments here in this, in this remaining 2 minutes, I can remind the audience of. So I think you can now see my screen. So I can remind the audience of our very last talk of these talk series, which is going to take place on July 15th by Professor Yasmin Hurd from the Icahn School of Medicine at Mount Sinai. And so we are going to, finish this series with this last talk, but we're hopefully planning for, the next round of our talk series. So I'm putting this in the chat box. You can follow us on Twitter for more news about the upcoming talk series and upcoming events related to ISAM-NIG. And also you can join our mailing list by sending an email to isam.nig@gmail.com to receive, the video recording of this session and also, the information related to our future meetings. And someone in the chat box also asked that, can we have Dr. Zhao's email? So Dr. Zhao, if you're willing to share your email address in the chat box, you can maybe put it here so the audience can maybe contact you further.
Sure. So maybe email me or email to you, because this is a recorded. Maybe everybody knows that.
Yeah.
Yeah. So please.
Great.
Yeah. Mm-hmm.
Perfect. So thank you all for joining this series of talk and this talk from our talk series. We hope to see you in our future events as well. Thank you, Dr. Rezvani, for hosting this session, and many thanks to Dr. Min Zhao for the great talk. Hope to see you all again, and goodbye.
Okay, thank you so much. Thank you, Dr. Min. Thank you, Parnion, for organizing this, and thank you, everyone. Have a great weekend.